doing their thing. Yeah. So the next session now is Janet Harris, who's a senior lecturer at the School of Health and Associated Research at Sheffield University, and she's been a fantastic ally for us really over the last 5 years or so, isn't it, for ages, and all the things we've done, but her particular bag is around peer support, and she's done a lot of research around it. So I'll hand over to you, Janet, to give us a little masterclass, and then we've got a bit of time for discussion afterwards. Again, I really want to give time for us all to have our voices heard, because it's the collective knowledge we've got that's going to be the most important. So over to you, Janet.
Okay. First of all, I'm not going to do a masterclass. Sorry. I'm going to try and do something different. I didn't bring PowerPoints. And the reason I didn't bring them is because the area of research that I'm working in right now, and have been working in actually, or trying to work in for the last 30 years, is something that's called community-based participatory research. Okay? And in England, I'd say that I'm in a minority group, not because of my accent, but because I work in this area. And we probably do about 1% of the research that's produced in healthcare. So it's not a method that's used commonly in health. But it is used in all of the environments around health. So it's used in ecology, it's used in community development, it's used in agriculture, it's used in forestry, and now it's starting to cross that divide, and more is being done in health as well. So how does this relate to peer support? We did a project, well, we actually started with the Chronic Pain Project, the Health Trainer Project. And to me, the Health Trainer Project was a really good illustration of how to do research with communities rather than doing research on communities or to communities. Because what we did, and I think you've had some other brilliant examples up here today, like Phil's team, is we worked together to talk about how does a program like peer support work? What do people actually do when they provide peer support? And why do the people that actually provide it and receive it think it works, okay? And to me, when I listen to Dawn and when I listen to Daniel, you guys actually presented the evidence, all right? Because what you were saying, we produced a model from this research, which we call the bicycle model. But what you were saying was that peer support is a process of getting to know each other. Sometimes you start out like this because the client coming in thinks that the health worker or the health trainer is some kind of professional expert, and they put you up there, just like you put the doctor up there, sharing a little bit about yourself, your personal experiences. And what happens then is that this starts to come down to people being on a level basis. The peer support workers and the client said it's about finding common ground, starting from the same place, getting to know each other, learning what the client needs, and then putting the client in control, which is our bike here, and asking the client what they want to do to make the situation better. And then doing the signposting, the information, the advice, showing people how to do things, the cheering them on, which is the affirmational support, saying, I know how you feel, emotional support, and providing information. So in our project, what we did, there was a group of us in the university, and also in the University of Alberta, so there were 7 of us on the academic side of the team. And I'm calling it the academic side of the team because there is a perception, which I would say, since I work in academia, I can say this, I think it's kind of true that we work in an ivory tower here, and that in this ivory tower we're seen to be the experts, the knowledge experts. And really what community-based participatory research is trying to do is take this ivory tower, here we have Rapunzel here, okay, let down the hair and get the people here who work in the communities together with us to actually produce the knowledge so that it isn't us doing it on our own. So we produced evidence from this peer support review. And in the process of producing it, we had over 200 people that fed back to us, people that work in communities. And our job wasn't really to come up with the evidence ourselves, it was as an academic team to package it. So to put it in a report. So we saw ourselves as being listeners, people who package something up, people who get people together and feedback knowledge and that link people together so they can share what they know about it. So the report was published, finally, back in May this year. It took almost a year to publish it. I think we started with Amir saying something about the speed of the NHS, which is here. And down here what we have is a totally different conception of time. Academia, I think, does move a lot more slowly when it comes to producing knowledge. So again, the CVPR here aims at trying to get these guys to speed up and pair them up with these people here so that we can produce something that's really meaningful to everybody. So what's happened with this evidence? It's very strong evidence. We had universal agreement on that model of peer support that you guys described. So not only universal agreement in the 200 people who participated in the review, but we've taken the review out because that is our job down here to do that as academics. So we've taken the review out to places like the Medical Research Council. It's gone to the National Institute of Health and Care Effectiveness. They invited us to provide, they call it expert testimony, which was quite embarrassing because we weren't the experts, you were. They're revising their national community engagement right now, guidelines on how to engage communities. Chris Neal is on that group, too bad she couldn't be here today. And we went and shared the findings with them, and the findings are in the new guidance for what's the best practice in terms of engaging communities. So the information is disseminating out now nationally, and it's now, we now have links with the World Health Organization, and they're using it too. So that's an example of how communities here can have a big impact nationally or internationally. But the thing I really want to talk about for the rest of my time is, now that we have this evidence produced in England, because it was people in England and a lot of people from Sheffield that participated, we have evidence on this program. But another thing that came up this morning was, what about the infrastructure around this program? And do infrastructures actually support embedding this program in the other services that are going on? And one of the findings from this review, which happened after we consulted everybody in the community, is we went back to the public health research, the published papers, and we said, everybody that we've talked to has told us how and why peer support works. If we go back and we read these articles that are published in journals by academics, can we see a description of this in the journals? Well, we could see a description, but what we actually saw was two different things. So we saw public health researchers up here and commissioners, people who fund services, designing a peer support program here. These were the people designing it. No community input. And they said, peer support is a great idea to deliver the message I already want to deliver. So what I'm going to do is, I'm going to find a person in the community that's just like the people we want to reach. And they said, that means they're the same gender, or they have the same condition, or they're the same color, or the same ethnicity. And we're going to parachute this person in to the community, and this person's going to deliver peer support, and by magic, people are going to stop smoking, lose weight, etc. So most of the research we found was this, okay? I would say 85%. And this research has a name. It's called authoritarian research, an authoritarian approach. Now, because these people up here are designing it. Now, authoritarian is not necessarily bad. Before I worked in academia, I'm kind of late learner, I came to academia at an older age. Before that, I worked in public health, and I was first a provider and then a commissioner. And in public health, when I was managing a communicable disease control epidemic, I would use an authoritarian approach. You have to go out when people are getting ill and tell them what to do. But we aren't talking about communicable disease control here. We're talking about what people need and what they want to do and how they want to manage their life. So most of them were like this. Then we found another approach, which was the one down here in the communities. And what happened here was a lot of people working together, the community-based participatory research approach. And from the ground up here, they decided what the peer support program should look like based on what they knew about the communities and knew about where they worked. So we had maybe 15% of our research using the CBR approach down here. And we said, gosh, this is supposed to be a review of all the research in the world. Which one works better? Authoritarian approach, or this one, which is called negotiated, because it's the communities deciding what the project or the service is going to look like. And when we looked at them, which one worked better? Yeah, negotiated approaches, okay? So what we did next was we said, okay, where does the money go for this research? All right, so here we've got this. We've got individuals here on this side. We've got collective. So are we researching individuals or are we researching groups? So if you think about the health trainer programs, a lot of the research on the clients you see are actually being done on, do individuals stop smoking, okay? So your smoking stuff, do individuals lose weight? Do individuals manage their diabetes? So it's condition specific down here. And this is where most of the research is, over here. Okay, that's what people are funding. Are people funding things up here, which is about, do communities change or support people who are losing weight, managing their diabetes, stopping smoking? Tiny number compared to all these down here. So we got a problem here in terms of the way the research is funded. So where does that leave us in terms of what we do with this peer support evidence? Because we know from all the work that's been done in this room, and that's been done in Sheffield, that the peer support is starting to work up here. So I think we need to move from our first project, which was a fabulous thing for me to work on, this one here. We have our bike model, we know it works, but how do we nest it in the broader context, which is Sheffield, or in communities in general, or in cities in general, so that someone mentioned developing trust, for example, between general practitioner practices and between health trainer programs. We've got all of these other services around here that it needs to be integrated into. And so it's not just about does the program work in isolation, it's about how does it work as part of a person's overall life, because again, it's only one part of it. So what we want to do next, and I'm saying we, because I'm trying to build a we here, and that's part of my agenda for coming today, is I managed to get some money from the National Institute of Health Research, who funded this original peer support review. They were really supportive on that. This time around, you had to apply for the money as an individual person rather than a team in a university. And they're called fellowships because what they do is they buy out your time, they pay your salary. And so I managed to get it, even though 4 days before I went for the interview, I leapt over a fence, ran into a lamppost, and went in looking like Mike Tyson to the interview. And what the money is for is to create not just an evidence base for one program, like the health trainer program, but the question is, can we create an evidence base for community-based services? Not just the one health trainer, but health trainers, social prescribing, health champions. We could go through the entire list because we know that a person in the community, when they need help, yes, they get a program there that helps, they might get one there, but really if you think about their journey through life, something that they learn in one place, like the GP, they go away, it gets reinforced somewhere else by the health trainer, they go somewhere else, might be swimming, might be exercise class, they hear the same kind of thing from another person. So the way that we actually get educated might start with the GP, but where we really end up figuring out and getting the meaningful knowledge is from all of these different places. So it's a social thing, it's a community thing. And what we want to figure out is, what's the network here of people that form the safety net for somebody so that they can learn how to manage their own life and not just sustain it, the 60% that have sustained it so far in the health trainers, but how do we help people so that they can sustain that over the long term, long after they've stopped going to see you because the funding only covers, for example, 8 sessions. So we're looking at how we can create this as a community evidence base for Sheffield. Now the reason we want to do that, people mentioned resources this morning, I think it was Mandy, mentioned money. We also know that people are applying for short-term money, and so you're constantly kind of lurching from one source of funding to another to keep your service going. And what we'd like to do is, we have this cycle back here, and some of this started from the peer support project actually. At the end of this project we had a bit of leftover money, and some of us here in the room and other people organized a day called Communities Got Talent. And part of that day was about trying to educate commissioners as to what was going on here with peer support, and asking commissioners how we keep this sort of thing going, so it isn't just some research project that ends up in a journal somewhere and nothing else happens to it. And so what we want to do here is, because commissioners said, fine, we understand you, but where's the evidence? You know, evidence from a health trainer program isn't enough. Evidence from a health champion program isn't enough. We need evidence that's going to show us we can justify shifting money away from medical services when they aren't the best people to be providing the service, over to non-medical services out in the community, but we need the justification. And so, and as we know, people who work in community organizations are people, they're not data collectors. So how do we collect this evidence and collect it in a format so that if we create this, we're going back to the commissioners here, and they're getting, commissioners and politicians, let's be honest, they're getting the hard evidence they need, some of which Aziz presented this morning, number of people who get better, number of people who sustain that, and we also attach that to money. How much are they going to save? Do they have enough evidence to go back to places like hospitals and say we need to move some of the resources away from you to communities out of healthcare? So that's the idea over the next 3 years. We're lucky because with this bit here, we have the funding now to evaluate the Transforming Challenge Award that Sheffield City Council is doing. It's the precursor to the Better Care Fund. So in this, we've managed to, and I shouldn't say managed because it wasn't a very hard sell, but we said to Sheffield City Council, when we're creating this evidence base, there's 2 things we could do. We could send the research team in the School of Health and Related Research out to collect data and to interview clients and patients, or we could train people in the community to do it. Because if people in the community are trained to go out and follow up with people 2 or 3 months after they received a service to say, how are you doing? You not only are collecting information, but you're also forging links between people in the community every day and the people in the community that maybe are lonely and isolated and not very, very connected. So they said that we could do the training. So some of the money that was originally going to go to us as interviewers, we're shifting over to this. So we're going to have a community-based participatory research training network, and anybody that wants to be supported in collecting information in the community, all sorts of projects like that one up there, can come to these workshops with us. We'll help people. They can bring in projects, things that they want to do in real life to find out what's going on in their patch. We'll support them, we can go out with them and help on some of it. We can pair people up so that you're helping each other. And from that, we're hoping that what we'll have here is not just the training, but that we'll have a research network. But this research network is not going to be a network that lives in the university. It's going to be a network that's facilitated by people in the university, but it's a network that lives in communities. So that's the direction we're headed in. So I know you asked me to talk about the evidence, but I think people have already talked about it really eloquently. And to me, the real issue is what do we do now that we have the evidence? Because we have an opportunity, and I think we have a real window right now in terms of funding to keep going with it. So if anybody here is interested about doing it, let me know.
That was much better than I thought, so let's introduce you as Janet. Thank you very much. you don't need a PowerPoint presentation to get across some pretty cool stuff.
Absolutely.
And I've deliberately put some time in now for us to have a bit of discussion along this theme around the role. Well, Janet's put some questions out there. Any comments or any sort of questions for me?
Can I ask you a question? I'm a CCG board member and I lead on long-term conditions, so I'm one of those people, I guess. What you're one of those people who make those sort of decisions about investments in populations and whatnot. My question to ask, and this is going to be me being somewhat cynical, of the time it takes from evidence to actually change practice. And the other thing is that at the moment we could produce all this evidence, but what happens if the money's dried up? And where we are at the moment is so you could sort of lead people up and say, here's the evidence that shows it works, and then they go, well, the coffers are empty. There isn't anything else now. And I'm just wondering whether there is some, yes, we do need evidence because we need to know that it works and doesn't work, and if you don't do it right, you could end up putting a lot of money into things that then fails miserably. The challenge we've got, though, is that this idea that there is already money there that we can reach out to, I suspect it probably isn't like that. We're in a world where we're going to start making really difficult decisions about whether we're funding, for instance, how often our bins are emptied on the streets, which is a huge public health measure, with how much we invest in A&E departments. And I was just driving past the Children's Hospital as I was coming here, and I could see the sort of department there and thinking, the needs and that needs bolstering and whatnot. But I was thinking if I had a child who's poorly, how do you get into the hospital? Because I didn't quite see the entrance. Do we start to think about how we invest in the communities? There's something inside me that's saying we need to gather the evidence, we need to be doing things, and I guess one of the things that this meeting has come back with said, well, we don't need the evidence, let's just do it.
But that's what community-based participatory research does. And I think that we already have an example with the Health Trainers Chronic Pain Program, because when we did that, first of all, we worked together as a team to say, what should the service look like? We developed a theory, why do we think this service will work? Then we said, how are we going to evaluate it? Everybody in the team had ideas about evaluating it. And then we met regularly, and when we met regularly, every time we met, we had some learning from what we've been doing. So we shared the learning. I think it was maybe once every 6 weeks, give or take some time. Every time we learned something, we changed the program. So that to me is the right kind of research. So, and we documented what we changed. So we showed it was a reflective learning cycle.
So you didn't have to go to the ethics committee to keep changing things, because that's the difficulty.
No, we didn't, because I
you have to plan something beforehand and try and predict how it's going to be. And
this tiny minority of people that does community-based participatory research has figured out how to go to ethics committees. So we go to them now saying that we do have a plan, but part of the plan is that we're going to change the plan based on what we learn as we go along, because the real aim of this research is to produce a service that people really believe works before the end of the research project. So the best research project to me is one where the publication comes out long after the change was made. And the publication is about sharing the learning with other people, but it's not a publication that gets people to adopt a service. It's sharing that learning. And during the Health Trainer Chronic Pain Program, we did a lot of presentations. I mean, I kind of lost count of them after a while. So we were out there a lot of the time talking to people about it. And that, to me, I think is what we need to be doing. That's how you generate evidence.
When it comes to Mandy, another CCG board member, I'm giving it away. But that's interesting, isn't it? What Janet calls research, we call continuous improvement of our service. Actually, there's a merge here, isn't there? There's
We call it generating knowledge.
Yeah. Sorry, Mandy, you
I
were
was
saying.
going to be making copies.
Oh, sorry, I've blown your cover now, yeah.
But I think I've probably got two hats on making this point. Previously, I worked for a voluntary sector organisation that held a contract for health champions in the city, and now I'm on the board of Sheffield CCG. And what drives me absolutely bonkers is that we're told there isn't an evidence base when there is.
Yeah.
And yet, loads of NHS resources are put into hospital services where there absolutely isn't an evidence base for a lot that goes on. So it's not treated in an equal way, really. But the other point I want to make is that the problem is, in terms of investing into this world, is the return on investment sometimes happens outside of the funding bodies responsibility. So, you know, organisation A may put money into it, but it's organisation B that benefits from it. And because of the way our world is structured, often commissioners work in silos, not because they want to, but it's just kind of the governance around how organisations have been set up. And there's always more than one commissioner involved. You know, we've got NHS England, we've got the CCG, we've got the council, we have the lottery. There's all these bodies putting money, short-term money, into the system in Sheffield, all at slightly different time scales, all wanting something slightly different, and not necessarily feeling they're getting a return on their investment, although the evidence is there that as a city, we're getting a return on the investment. And I think that's something we've got to tackle.
And that's the issue under the community evidence base. That's the issue that we want to tackle for the fellowship. And I'm saying we because in order to get the funding, you have to get people to sponsor you, and they have to be people in the organizations that you want to have change. So the head of the clinical commissioning group sponsored this, and the head of the Sheffield City Council sponsored it, and the leader for the community well-being team and public health sponsored it. So the people that are in these separate organizations have all said that they want to support something. And one of the things that this is aiming to do is that thing that you said about some knowledge gets valued more than other knowledge. It's true, it does. And so somehow we have to create a level playing field where all different kinds of knowledge get valued equally because they're all really important. So the funding that I get is through something called the Knowledge Mobilization Program. And what that means is you're taking knowledge from all of these different places, including the community, and you're brokering it. So you're getting people together to share it, and getting them together in a way so that they can understand that the value of all different types of information is just as important. And then getting them to problem solve here. And out of the problem solving, what we hope will happen is that there'll be a shared fund like there is now for the Transformation Challenge Award and for better care. And with the shared fund down here, that they're going to break down some of these silos, and that the commissioning that happens at the end of the day will be for integrated services rather than little pots of money here and there.
I love that optimistic.
It's a big
Gary,
I think this is the future. I think you've struck a chord. I think organisations that actually come on board with this will actually benefit. There's knock-on effects for social animals. You're bringing people together as a group. You improve mental health, which has a knock-on effect to the NHS, stops people going to GP surgeries. So when you talk about cost, talk about millions, billions of pounds potentially. So I've had a conversation with Newcastle University along the lines of engagement within the community, patient engagement, and the knock-on effects that has. So, you know,
We work with them.
Pardon?
Newcastle. They're part of the, we're setting up a new UK participatory health network, and Newcastle's
With
one.
Professor Thompson?
No, we're not with him directly, but Tina Cook, who works with them.
Okay, well, I spoke to Professor
Yeah.
Thompson about this. But anyway, I think this is the model, this is the future. Community-based activities, bringing people together, sharing knowledge. Even in this room today, the experiences that we're all sharing, we're all learning from each other. That's the future for the healthcare service, because really, you know, NHS should be focusing on chronic illness and self-care, awareness. That's the future model.
Yeah.
And
and I
you're
think
ahead
it's
of the game.
here.
If
Well,
you did,
it's
you know.
not me though, it's everybody in this room and other
Yeah.
people.
I think
You know?
the problem we have is we need to empower others. So it's like the ripple effect. We have to spread the word, and because a lot of people in here in this room, we have an interest in healthcare, but there's others out there that don't, and they're the ones actually we need to tap into. And it's how we bring this model to the next stage.
And we need to get the National Health Service and places like National Institute of Health Research to understand you shouldn't be funding an individual. Okay, I'm getting to the point of kind of we went through discussions and now we're getting to the argument stage. Because this isn't about me being a broker, it's about me listening and finding out all the people that are already out there that connect each other together, and then make sure that people are connected with each other. So it's that kind of thing. And we should be funding that instead of individuals.
Right.
I just want to ask a question about sort of two questions. The first is about this, you know, the whole idea of networks and how they work. and messy networks where they're all interconnected, which is a bit like this room, I think, and how everybody knows each other, and it's very organic. And how you apply that to this, because I think that's one of the special things about community. And then the other thing is about the value of digital in scaling this up and getting the message out there and supporting other people in other places to get involved.
With the network bit, I asked for money to do network analysis, because I think this is about people. What the learning for me that came out of the peer support review was that, okay, we have services that really work, like health trainers, things that are done in the community well-being programs, but if you drill down under that, what's under the services that work is relationships. And I went into the research and I really tried, and I don't want to sound like a clever klutz, but I teach people how to search for research. Now that's what I did for 10 years at Oxford. I couldn't find any research on relationships and social networks that showed that they're the thing that makes something work. So it's like no one's putting the money into that side in health services, health research. Okay, it's in social sociology, and we do have social capital stuff coming out now, but no one's actually saying what are the networks here, and what is it that makes these networks function really well. So what is it that makes a health team program that signposts to other services function to the point where this person here has this kind of seamless safety net for themselves, So what we want to do is some organizational mapping to see how different organizations work together and where the gaps are. And again, that would be learning. So when people who are doing the mapping see that there's a gap, maybe you guys in ShipShape want to refer someone somewhere else and you can't find the right place. We can identify the gaps and feed them back to the City Council. And the City Council has said that they'll use that information every 3 months to try to make changes in the way that services work together. And then we thought also on the individual level that it's about how does the people who are lonely and not socially connected, we know that there's a lot of health issues there. So what is it? How do people actually set up social networks for themselves when they get this sort of support? And with that, there's already, and I learned this just from going out and doing that kind of brokering stuff, there are tons of case studies in Sheffield. Tons. We almost don't need any more. We have a library there. I think it was Joe Fowler said, I don't want any more qualitative data. I could wallpaper the town hall with all the case studies I have. But
It's
how do we use
commissioning
them?
lead for the councils in Joe Fowler.
Yeah, and how do we use those case studies? And you can go back and look at those, and we're starting to do that now with those of you who produce these, and we're saying, what works for a person, and then how do we translate that into money, in terms of saving money, and how much does it actually cost? And some of these services, like Lorraine Jubb was saying the other day, the new service that they have set up now as part of this transformation challenge, which is to have key workers in the community, sorting people out, providing them with support, helping them navigate through things. They costed that out. For one client in there, they only have to pay £11 to get things fixed for somebody.
97p if it's a health champion.
Yeah. So this is the kind of thing that we need to be collecting alongside the evidence that it works to show that it doesn't just work, that it's cost effective.
That's not what I was, I think I left them in the wrong way. What I meant was that this is really brilliant stuff that you're doing here. How do you get this out? How do you share this?
That's
so
why I
that
need
actually
you.
influences.
And you were next on my list because, and this is about not waiting until the end to share what you're learning. It's about sharing it all the way
So we
along.
do it at the
And
same
you and I
time.
have a date in the diary. I think it's next week, maybe.
Yeah, I think it is.
Because I wanted to ask you for some ideas about how to do that.
Yeah.
Because I'm not the brightest bulb when it comes to social media, and I really could use some help with that.
Janet, can I share something personal for myself then? So at the moment we all do appraisals. You'll all have heard that doctors and nurses now have to do appraisals. So I've just recently done my appraisals. I'm going to share a little bit of it. Doctors are expected to do 50 hours worth of learning, and so like today, I spent 6 hours. I'll reflect on it. I can put it in my appraisal, and I can say what have I learned and what difference has it made. My appraisal last year, I did about 120 hours worth, so it was 2.5 times more. But when I was reflecting on my appraisal, I figured out that something like 80 to 90% of my learning was social media, was Twitter. It's that Mark Zuckerberg, 1 billion people on Facebook hit us. Do you think anybody inside the NHS has actually considered that for a moment? And I did my 130 hours, and I'm telling you now that 80 to 90% of my learning was through Twitter. And yet, not a single moment of that went into my appraisal. So my 120 hours was independent of all the stuff that I've done. And that's because it's not quite, it's much easier. You go to a lecture, you sit there for an hour, you get a certificate, you get CPD point, you can record that, you then share it with somebody else. There is something about that Mark Zuckerberg world, that Facebook world, where that's where people, not everybody, and we do need to think about the excluded, those who aren't digital, and how do we support them, because it's not for everybody. But nonetheless, there is something going out there in the community, and organisations really struggle to understand what that thing is, and yet that's how people are building networks and systems and things now, rather than the traditional model of come to the town hall and listen to a speech and AGMs and whatnot. You might have one AGM, but that's not really how people are learning now. But how do we capture that?
University, same thing. Big chunks of the university are not on that digital wavelength yet either. They're still with the traditional lecture rather than the information sharing, and I think we really need to move them along too.
So how do we do that? Other people in this room, because we're all must be active. How do we?
I think the first person I saw moving, trying to get
Well, I was
attention
just
with Lynn.
thinking, I was just reflecting on what you said, and I'm thinking about my son who is 28, and he has learnt digital skills from 13-year-olds in California by using the internet, and so his learning is also that way. And I think it's, how do we get that out to the masses? I guess we need to ask the young people, because looking around this room,
We're all too old.
we're all a bit older. It really is, how do we engage with those younger people? Gareth is sticking his hand up.
He's
Yeah,
young.
it's not
It's because he's
easy.
young.
Like, how we actually get that is we go to the people who have millions of followers. So your Wayne Rooney's, your Manchester United's, and you engage with those, and they have the critical mass that we need. You can also put all this knowledge on a kind of a virtual platform, and that can be shared so the people in the room, we can disseminate that information across the masses. But there's a new model there that we can follow. We're not tapped into it yet. Organisations haven't come around to actually understand the value of it, but it's enormous. We get people involved who are ambassadors, because remember, health and social care touches everyone. So the likes of your professional footballers, your movie stars, your David Beckhams, they all use our health services. Are you telling me they're not willing to give up their time to help others? Yes, they are. So why not ask them? Why are the NHS not going out there and actually saying, look, we need your help, we want your support? Because they will turn around and give it. I've absolutely no doubt in my mind that they would. And then they send a message out to critical mass. It's the same with the Premier League football clubs. They need to buy into this. There's some interesting work going on with Everton Football Club at the moment that I've linked into with a guy, Colin Doyle, who's doing some community-based activity. It's about mental health and the advantages of people getting involved in the soccer and the endorphins it released. And I'm trying to get that kind of link going so that we can share that knowledge. And that's your platform. It's there. It's not. Everyone in this room has the ability to tap into that as well. Don't think, sign up to Twitter, sign up to Facebook, get involved. Share your ideas.
Yeah, we need to remember to write them up there too, don't we?
It's the ripple effect.
Scotty, do you
I
want
think
to-
for me, I want to answer Amir's question.
Yeah.
I think the one thing, I'm yet to see a policy that an organisation or service holder doesn't say what you can't do with social media. It's all about what you shouldn't put out there, what you shouldn't put out there. Almost like, organisations are afraid to take a risk. I've gone to a new organisation and I've actually been given a licence to set up a policy where you're allowed to say, this is what we should be putting out there. So rather than handcuffing people and telling them what they can't do, just give them a broad guideline about what they can do, rather than
help them out?
risk aversion, I think it is.
That's a good
How dare we share
That's
that?
a good idea. The university could use that.
I think lots of services, teach university endemic, I've looked in a lot of services
Not
where
always.
don't share that, don't give that away.
Did I see someone else waving their hand? Yeah, Adam.
The phrase has been running through my head all morning is just do it.
Yeah.
So the evidence is really important. and the people who make the decisions are really important. But I'm with the comment that was made over here. I think there's a serious risk that the funding is just not going to be there to support the kind of infrastructure you need to make this work. So I think, as well as just, I mean, I've been so completely inspired by everything I've heard this morning. It's just wonderful, it's magnificent, and it needs to be happening everywhere. So why don't we just do it? We know what works. The evidence is great, and the evidence will continue to accumulate. But we know what works, so let's just make it happen. How do you make it happen? The one thing we haven't talked about is behaviour change. And I'm not going to be like some advocate for the dark arts of behavioural science or anything like that. But I'm sure there are many ideas we can tap into, which are all about those little nudges that get people to do things in different ways. I suppose here I'm really talking about the majority of people who are not going to need the more intensive support that we talked about today, but can be activated and empowered to go out into their community and create and construct these networks so they're all supporting each other peer to peer. A couple of examples. If you want people to put loft insulation in, if you tell them at the same time that you'll offer to clear their loft for them of all the junk that accumulates in there, then they're much more likely to take it up. There was a city, I think, somewhere in Spain where to combat a massive litter problem, all they did was put little footprint symbols leading up to the bins. And overnight, it just completely transformed the city. I mean, it was just astonishing. So those are just, kind of silly little examples, but they're also really telling. And I'm sure there is something we can do if we all come together, not just in Sheffield but across the country, to drive that kind of social movement that could be self-perpetuating and carry this amazing work along on its shoulders without necessarily needing the funding from the commissions.
I think there's a window to do it with this, with the Sheffield thing. So who is
I think what we did with Men at Work is a good example of that, because we did just literally go out and do it, and then the funding came from the lottery. Fingers crossed.
And the community-based
Because you just do it and then you demonstrate that it works. Then you're creating that critical mass of awareness that the funding may
and
it's just this risk that the funding is not going to be there.
To add to that, the community-based participatory research network, we set one up in Hull. That was set up 20 years ago, and it went on its own with no money. People helping each other out like you did in Shipshape there with the project for 18 years. So it was Helen next, and then I think Dan, and then, yeah.
I'm really interested in what's happening nationally and politically, and whether actually, whatever our individual political views may be, there's something different kind of happening. It feels like there's a real shift. And I wonder whether that is going to absolutely link into what you're talking about, and that kind of, that mass shift might happen and might actually be a tide that kind of moves this kind of work forward. And I just wondered if there's any linkage or any thoughts between, I know we're very, very fresh into new stuff nationally, but between linking kind of national change in people's behaviour and thoughts with this kind of participatory PMQs where we have people, tweeting questions for Jeremy Corbyn to ask today, just all that kind of thought process.
I think that's what we need to be doing. That's the link between the evidence and getting things to change. And I think you can do it with what's happening now, but you can also try and forecast what the next national interest is going to be. So when we talk about just do it, right? I would argue, yes, we should just do it, but as we're just doing it, we also want to keep this little evidence pipeline going where we're constantly producing knowledge about the value of what we're doing. So it goes like this, and what can happen along there is, and so some people in the university would be totally shocked to hear me say this, but you produce a little evidence, you tweet it out and disseminate it in other ways, you put a spin on it for what the national interest is now so that people will pay attention. You're not changing the evidence, but you're packaging it in a way so that it's going to grab people's attention. Then you get a little more money in. You apply for what's called research money, but it's really research money to do this community-based participatory stuff. And then you can generate the next little bit while you're just doing it, right? And keep framing it so that the money keeps coming in.
So the research is actually helping sustain the service along the way.
Yeah, which is the part that people don't like to have said, but I think that they should be integrated. Because right now we're funding programs and we don't know if they work or not. So you could argue that's a waste of money, so we should just combine the research money with the program money.
Brilliant. I wanted to, in response to your behaviour change thing, Martin, I know you've been doing behaviour change for you guys for many years. Did you want to come back on that, or you had a different?
No, I suppose a point question really for me was, I completely agree with just do it. And at the same time, I think the points made by Amir and Mandy are important too, because I suppose yours was, is there any money to shift? Well, there's 100 billion. Then so there's an important question about how we get it shifted. So I think we have to do both. I think we have to just do it, those of us that have got control over ourselves and what we do and the people we connect to, our relationship need to do that. But we are going to need to, if we're going to see some really big shifts over the future, we are going to have to change how the health service budget gets used, and also we're going to have to deal with this issue of CCG funds something, the benefit comes to local government. We're going to have to do something about that. And I guess there's a challenge to you two and all of us about practical ways in which we can get that to happen.
At a very simple level, wouldn't it be great imagine if you are now the person that's on that board, and each and every one of you, and you're now being asked to make that decision. I agree with the £100 billion, but then similarly, 70% of that is staff. So if we're going to start shifting money, someone has to make a point a finger at a person, a family, a group, and say, I'm sorry, but we're going to end that job, because we can spend that money in different ways. And at the moment, fortunately or unfortunately, there's been other people who've been able to make those decisions. And my feeling is part of this idea of co-production is that if we are going to do this together, it's not just talking about what we can do, but it's also about making some of the really difficult decisions. Sometimes we feel as though, well, actually, I'm really glad someone else is making that decision, but actually we can't do that anymore. We need to work together and start to believe that each and every one of us in this room could be on that board, standing there. So it's not just me and Mandy, but you're actually sitting together with us, because I think that would be an easier discussion to have together rather than doing it to people.
It's just a quickie, but I appreciate that we have to keep coming up with evidence about why we should do it, but we also need to look at the risk if we don't do it, because I think we can predict when the money's going to run out, basically, with an ageing population. Yeah. So to turn it round, what's going to be the situation if we don't? We're just going to, and the money that's sort of also being, taken away from some of the council services. I think we need to think a lot bigger, and we already are doing, I suppose, with libraries, and it might not be the ideal route, but think a lot bigger about how we can roll out this sort of all getting involved and taking more control back to other services as well. I'm going to have to, or else.
If we take the example of the steps taken to the bins, but if the council decides to cut the emptying the bins, then we've got a major problem.
Yeah.
And that's exactly where we're possibly at the moment. That's why we need the community and those making the decisions working together, because otherwise you find all the bins are full, but actually we haven't invested in emptying those bins.
Just on the funding, I think it's closer to about 180 billion that you're talking about. But also, remember that it's the community actually who will drive the services. It's not the people who make the decisions, because you are the empowering agency, so everyone in this room is actually making that call. So you take the responsibility. That's where the power is, not in the people who think they're making the decisions, because that's not where the power is. It's actually within this room. So that's where it's at.
I was going to say, bringing it back down to shipshape again, is one of the big successes that we've had, that Chris and Ben did the presentation on, was Men at Work. And that was an example of something that was a just do it. That was something that came from Ben himself in the community, that started through volunteers, that started to become established, applied for funding, and it's growing and growing and growing. And the amount of funding it's getting is not very much, but it is reaching a very hard to reach group of people who are men, who are statistically more likely to be involved in risky behaviour, suicide, health problems, and all these kind of things. And the other thing that's addressing that issue as well is the football, which Chris mentioned earlier, which has been running for quite a few years now. Do you know about the football? Yeah.
But other people like that.
It was set up, it was actually a guy who I did ICDH with, and it was his end of course project, was to set up a football group, a football tournament that specifically addressed men's health. So the people who were taking part, there were guys who wouldn't normally take part in physical exercise. They were from organisations like mine and SAS, who deal with alcohol rehabilitation, and working with men who had neglected health, who were isolated, who had substance misuse issues, and actually bringing them together to engage in physical activity, and to reduce things that we mentioned before, like isolation, mental health problems. And that's something else that came out of the idea of one person in the community, and that's now been going, is it 4 years?
I think this Sunday's is
4 years that's been going for, and the guys who take part, they set up football teams, they continue to practice and play outside of the tournament, and that's a legacy. Again, that's not cost a lot of money, that has had an impact. So I think, as well as looking at the bigger picture, I also wanted to sort of draw attention to the small things that have happened through ShipShape, and these have had big effects on people's lives and health with very little money.
It's the kind of thing with digital media could be.
And I think one of the things I'd want is you need to put feelers out into the community, going back to the community, that there's assets in the community, there's people who've got ideas, there's people want to do things. It might not take a lot of money. Use volunteers and use health champions and things like that to get things going.
Yeah. Roz, I think you would have.
That's fine. This may not be that popular actually, but I think so there's a few elephants in the room right now, and one of them is about power, another is about culture, and another is about the sacrifices that people make to make these things happen. And it isn't that easy to go out, to do what you've done. I expect that, and we're sort of, telling the best of this today, but behind that is masses of work, loads of sacrifice, no sleep, not very much money, and all the rest of it that goes with that. So it's really hard to do this work. It's not easy, and you can't just do it. And there's something about this power and culture business, and I mean that from a system point of view and also from a community point of view in this country, and our expectations around health and well-being and all the rest of it. And it's really difficult for some people, I feel privileged to be in this room and to know all these things and have this knowledge. Not everybody has that. But on the other side of it, we all have a responsibility now we've got that knowledge, don't we? And on that note, in terms of influencing the system, I gave up influencing the system a couple of years ago. I worked in the NHS for 8 years, and I thought, and I learned lots of, I was really privileged because I was involved in community health champions and those sort of things. I had the best bit of the job in the NHS, I think. And I learned so much that I thought, actually, we're always banging our head against a brick wall because of the power and the culture issues in some ways. And I'd rather go and support the community the people in community to feel stronger and more empowered and to do the things that they want to do and tap into their own ideas and talents and all the rest of it. I think that's the best thing to put my energies in. So in a way, that's kind of turning some of this on its head. Let's not face the system, let's support people. And then, the system is starting to notice now, aren't they? And there is lots of, as we were talking about, there's loads of value in doing that. So, yeah.
Can I try that? Sorry, Matt, you
I hope it comes out right what I'm trying to say, because I'm not quite sure what I am trying to say, but I slightly disagree with your point that, and I don't mean to sound argumentative, that if we're going to put money into this, invest into this, it means a job goes somewhere else. Because actually, what I think you can do is work in partnership and do things differently. And I'm thinking of something we're trying to do in Sheffield, and it's very, very early days, but work very differently with the Hallamshire and the Northern General. So instead of just contracting them for numbers of people wanting hips and knees and God knows what, we're contracting with them for results and outcomes, including improved quality of life. And we're saying to that hospital, you've got to work with other organisations to deliver that. So it's a real kind of shift in how we want to work. So I think there could be ways, and we found it really hard to do that. I'm sure the hospital will find it hard to deliver. And it'll be quite interesting to see what kind of partnerships that are built up. But what you were talking about, ShipShape, if we want to reduce the number of hips and knees that need doing in Sheffield, we need to get to people much earlier so they remain healthy. So I think there are ways forward, and I'm not underestimating the financial problems we all face at all. But there's a huge amount of money going into services in this city. We can shift it a bit, I believe.
I was just going to say, with the unfortunately, with the current government, we probably have to use our evidence to tell them how much they're saving. So this free medicine can save them a lot of money. Because the medicine they're giving in the pharmacies is worth pennies. Like paracetamol in suspension is worth pennies. but that may be keeping them out of the GPs. If there's a free Calpol, we were told by A&E that a bottle of Calpol they give there is worth £60, in effect, you know.
They do want to know what they're saving.
So we like our football, we love our football. It's harder to prove that's going to save them money, isn't it? So maybe we need to use our evidence to hit them over the head. Like, for example, childcare as well. The current government is going to increase the amount of free childcare for 3 and 4 year olds to 30 hours a week. But that's not because they love children, it's because it removes the excuse for people to go to work. Women's excuse, I can't work because I've got childcare. And that was the same in the 80s with when they first started funding childcare.
Yeah, but I think we need to ask them, when they say they want savings, we need to say savings on what? And have a dialogue about what does savings mean, okay? So for example, right now with the Sheffield City Council one, they want reduced hospital admissions, reduced A&E. And I'm laughing because I can remember arguing with this a few years ago. Now here I am having to evaluate it. So it's come back to haunt me. But it's about negotiating it. So we said, okay, we'll see if we can measure that. But we also have to measure all the things that happen before somebody ends up in hospital or avoids hospital. Otherwise, that thing about saving money on the admissions doesn't mean anything unless we know why it's happening. So I think it's a challenge of giving people what they want, but at the same time trying to give them things that are going to help them make sense of that evidence.
Yeah, I mean, the thing that keeps striking me, what I'm hearing as well, is that a lot of it's about teamwork, isn't it? There's, you know, you people like myself and me, we've had 10 years of training to be able to recognise when something might be cancerous or when, you know, what medicines to use and so on, and I've gone through all the science side of it. And people want that. They want to trust that when they're going to get that viewpoint. But there are other times when we can't deliver. The stuff that we've got is totally useless, you know. And Dan and John described that situation incredibly well. You know? But how do we know when it is the right time to do those right things? The system's got to keep talking to each other so well, so that you don't get someone giving bad advice because they don't know what they're talking about in the wrong situation. And that could be me, or it could be Dan or Don. You know, if we're in the right, you know. If for a long time we used to tell people when they had back pain, you should just sit down and rest. I mean, we know that's totally wrong now, in fact very damaging. Still a lot of people out there believe that. You know, so if you get people connected in the wrong way, you can still get bad stuff happening. So that it's how do you create that sense of teamwork that allows us to know who's the right person at the right time. I mean, I think this is a great move in the right direction, but that's a challenge to us, isn't it?
We need different people on our team. And that's why the health trainer one worked. There were so many different kinds of people on that team. And what we're trying to do here with the city council evaluation is get everybody on the team. So we're trying to get the finance people on the team that are saying, I don't care about any of the qualitative data, I just want to see what we're saving on the admissions. But if we can get those people on the team, then the aim is that you start to look at this from the perspective of the other person rather than sticking to your own point of view. And I think the more you can start to understand other people's perspectives, the more chance we have to maybe find that thing like Laz was saying, an entry point where you can make a change. And so it's about getting it away from the silos.
Can I ask, again, people in the room, the power of patient stories? I'm sure you use them in CCGs in Sheffield, and we do in Manchester, and many boards now start with a patient story. What's your thought about that? Do you find that that's been helpful in some of the decision making, or do you feel it's been somewhat kind of, we'll start with the patient so we can tick the box that says we've had a patient story and then we'll do the business? Is it a powerful way of trying to bring the person into the decision making process?
From our perspective within Sheffield CCG, it's quite a new way of doing stuff, but we've recently started developing a respiratory strategy. It's really off-putting.
Sorry, I'll repoint. So we know who's talking about.
Yeah, so we've recently started developing a strategy for respiratory where we've the commissioning manager actually, who's led right from the very beginning, kind of the need for a change in strategy within the city, right through to starting to then went through a period of engagement, semi-structured interviews with individual people. We had a partnership with Patient Opinion where we were encouraging the services within the teaching hospitals to encourage people to share their perspectives, and just a variety of different ways. Went out and spoke to Breathe Easy groups and the voluntary sector, etc., etc. And what he's always said back to me is, I now have those people with me when I'm sat in the meeting trying to negotiate how the service should look in the future. So I've got their voices in my head all the time. And that's far more powerful than me going out and talking to people and then coming back and sharing that with him as he then goes to develop the strategy and how we move forward in the city. So that's, I can't say that's necessarily been easy as a cultural shift within the organisation, because it really does feel like that's a different way of working. But actually it's immensely powerful, and that is then being proven through action as we move forward.
Yeah. The last two here, then I know lunch is outside, so we'll put because we've got more time at the end to have it.
In response to your query, Health Watch do something very similar to the research that you do. It is all based on evidence gathered from communities and individuals, and it's those stories that we take forward to CCG, for instance, and write reports and make recommendations. So that's how we do it. So it's working bit by bit.
Scott, can we just hit this chat from
Yeah, I'm Roy, my wife Rosemary. We're not part of organisations, and we've heard a lot of good information, new information, organisations this morning we didn't know about. I'd just like to go off on a different point. We mentioned the Just Do It, and particularly the self-help. But at different times particularly over these last few years, coming out on TV, and I don't know whether it's politicians or education, etc. But somewhere, as I say, whether it's politician or education, seem to be pulling the other way. In other words, don't just do it, don't just self-help, because we keep saying things and we keep saying, but that's not the responsibility of those people. It's the responsibility of the parents. And I'd only make one example, and by all means shoot me down, because we only have grandchildren now, we haven't got children at home. But a good while ago, as we all know, one thing that happened, and there is other things, different things that happen in different time, but one thing that started to happen, we heard about young children not having breakfast. So they started giving breakfast at school. Now, we don't want to see any young child go without breakfast. And obviously, what they're doing now is very helpful. But that has taken the Just Do It and the self-help away from the parents, particularly the parents who can't be bothered and think, oh, I'll have another half an hour in bed. I haven't got to get up to give the children the breakfast. So are some organisations, or politicians or whatever education, pulling the opposite way, which we don't like to see. In other words, they're taking the self-help and the Just Do It away from the parents, and we don't think that should happen.
Well, I think that's a fantastic point to end the morning session on, because that's something for us to be mindful of, perhaps going into the afternoon, actually, that where you have unintended consequences of well-meaning things, but actually that we have to be mindful of what undermines people by trying to be helpful, isn't it? And that's a great point.